So next, to keep this moving, we're going to invite Chin Her, who I've known for a few years now, but surprisingly not as long as I should have known him. He is currently a professor at Columbia, and he has a long history of actually studying Barrett's esophagus, which I keep on saying is the analogy to gastrointestinal metaplasia for the stomach. And fortunately, recently he has started to migrate down south into the stomach, and will be focusing efforts on that. So with that, I actually gave him this particular topic, and the reason, I don't know if you know why I gave you this topic, but it is because Doug Owens, the chair of the USPSTF, said that this is the most important, or one of the most important questions. What is the burden of disease? Because that is something that they take into consideration when making guideline recommendations. So I hope you realize how important this talk is, Chin. We're depending on you.
Yeah. Thanks, Juho. Thanks, Care. Thanks, Robert. So as a solid Northeasterner, I was foreign born, but Brooklyn, Long Island, spent 8 years in East Baltimore, 20 years in Boston, and now back to New York in July. We always poo-poo the West Coast, especially places that have 350 days of sunlight a year. But coming here again, it's a little more tempting. I'm trying to still believe the lie that I like temperate climates in winter. So this has been fantastic. Now, I will say one negative to balance the positive. I thought the schedule was set around my acceptance and not Dr. Ko.
Sorry to let you down.
That's okay, but I get to go after him. So I have no conflicts related to this topic of gastric cancer. Some of my funding, though, is in upper GI cancers, predominantly esophagus, as Juho's mentioned, as well as pancreatic cancer. So the question that I've been assigned, but I embrace and am thankful for, is there sufficient disease burden in the U.S. to warrant gastric cancer screening? This is a broad question, and we've touched on this, and even my speaker after me will continue. There's a lot of overlap in some of the stuff that we're talking about, including the great presentation regarding cost effectiveness. And the answer is, I'm trying to be circumspect. I know I'm a believer, but I'm trying to be scientifically rigorous and circumspect. It depends. So for mass population, like colon cancer, breast cancer, and there's only 3 in the US, right? And cervical cancer, no. Because in the American context anyway, it's pretty expensive, invasive, and as Dr. Hanamai, from the professor from Taiko University said this morning, there's a lot of over-testing, and we need to be cognizant of that. However, yes, for targeted screening in high-risk groups or individuals, definitely. But we need to be thoughtful about this and not make blanket statements. We need to study this and be rigorous, and it depends on the level of risk, of course. So, I'm in a screening conference, but let me be the Grinch here. There's been a little bit of a pendulum shift, right? And there's terms like over-testing, over-screening, and over-treatment. And more is not always better. And so I do cost-effectiveness analysis, but it's not just cost savings or cost containment, as nice in the UK. One of the examples is the prostate cancer story, right, where we had to de-implement because we were doing significant disutility because many patients were undergoing radiation or prostatectomy when they would not have died from prostate cancer. And similarly, we went through something when I'm part of the NCI CISNET consortium, and I'm not part of the breast group, but when some of the data to take back mammography age, it was a public outcry. And the justification was for the disutility of false positives, not just the cost savings. So I think we need to be careful, even though I'm fully supportive. I think we need to be rigorous in terms of the benefit of screening. So this is what we call in cost effectiveness a league table. So let's look at U.S. incidence, and many of this. Lung cancer is the #1 cancer now, and although breast cancer just is in terms of mortality. So we only have screening as a mass screening for colorectal, breast, and cervical cancer. Pancreatic cancer receives a lot of attention because of the case fatality rate and because we've made so little progress. But as Dr. Huang alluded to, there are, quote unquote, only 18,000 cases of esophageal cancer. And specifically, the one associated with Barrett's and GERD, or gastroesophageal reflux disease for the non-GI people in the room, it's only about 10 to 11,000 cases per year. So definitely more gastric cancer cases. So, and this ties into the precision medicine. How do you avoid overscreening and overtreatment? Of course, it's risk stratification. And we want to identify the patients who will develop cancer and not subject those who will not to all of the testing and the false positives. So if I boil it down big picture, screening, we have to look at it in a comprehensive context, not just the beginning, but all the way down to the treatment and within the spectrum of cancer care. So this is overlaying a mock-up of the Korea cascade, of course. So there's screening and surveillance, and screening, and I think the next speaker is going to talk about HP test and treat, so I'm not going to get into that. But for example, why does colon cancer screening so effective? And in some ways, I'm very proud to be an endoscopist because we can prevent anywhere from 70 to 92% of colon cancer with screening and surveillance. I mean, that's a really big deal. So we can't say that. We have to be rigorous about this. Is it the same? Now, with ESD, EMR, ESD, we may approximate it. And finally, in Barrett's, with RFA and EMR, we have more of a prevention because it's more of a preventive effort if you can identify precursor lesions, high-risk lesions, and prevent it, right? So there's this whole complex of the disease, the natural history, and the potential interventions, and we have Dr. Umar speaking next about prevention, including chemo prevention. Aspirin's in the doghouse. Hi, Andy. For now, but there's other chemopreventive agents such as Dr. Wilson is doing a DMSO trial, I believe, in gastric cancer. MEK inhibitors, also Dr. Goldring at Vanderbilt. But now I'm going to focus, and these are areas that we can improve, and this is a multi-level, multidisciplinary approach that needs to be tackled. But the other part, of course, is the individual patient or the subpopulation and their individual risk. And that's where I'm going to focus on a little bit. So, for example, in the U.S. context, we talk about endoscopy, but in other parts of the world, serum pepsinogen. And serum pepsinogen is targeting this portion of the chorea cycle, right? And perhaps a multi-step screening process, such as those who are positive might get screened or receive an upper endoscopy for the presence of dysplasia or intestinal metaplasia with subsequent chemo prevention or some kind of other intervention. And then, for example, screening this whole linear process can also be changed if it's not endoscopy, let's say, but you come up with something really low cost, non-invasive. So cytosponge isn't cheap, but let's say something like that in the esophagus where you can have cell sampling. We already talked about the chemo prevention. So tomorrow I think we'll hear more about molecular biomarkers and precision medicine. And when we hear precision medicine, we're thinking genomic markers. So I'm not trying to poo-poo that. I think that is the future, and I think that's very important. But when we look at polygenic risk factors for cancer, I don't think anybody has exceeded an odds ratio of 2. Now, somebody correct me if I'm wrong. Maybe in breast cancer it's a little higher. Colon and esophagus, it's very low. So I'm a public health person by background, so this is something we did regarding esophageal adenocarcinoma risk stratification. And there's 5 major risk factors, and this is a complex figure, but we rammed in smoking status, BMI, whether you're obese, overweight, or normal weight, GERD status, race, and it was just white, non-white, because there's not much data, and sex. And so if you do the permutations of 2, 3, 2, 2, you get 48 patient profiles. And what we found, no molecular biomarker, the highest risk group, positive for anything, a white overweight man who smokes, who's overweight, the relative risk is over 600 times greater than the bottom reference group, which is the negative of all of those. And that's a pretty powerful biomarker, so to speak. So there's some limitations of this analysis. We had to make some assumptions, of course, and we work closely with the Beacon database. So I want to acknowledge Aaron and Tom Vaughn. So what are the risk factors for gastric cancer? So we know some of we've heard of these: family history, autoimmune and chronic inflammation prior gastric surgery. We're going to hear more about H. pylori. Diet's big, and perhaps that's why the question, why do East Asians have such high rates? But I'm going to focus in and zoom in a little bit about race, ethnicity, foreign-born status, and country of origin. So this is actually, Juha was part of this study with John and Indomi. Is John calling in later?
He might be on the WebEx.
Okay, John, if you're hearing, I'm giving you a shout out here. This is done in Seattle, I believe. And this is looking at gastric cancer incidence rates globally. And it's the same rate, about 5 to 6-fold in South Koreans, 3 to 4 in Japanese, and 3 to 4 in Chinese. And in this paper, I'm not showing it, they also found in U.S. Counterparts, so Korean Americans, Korean foreign-born, that these ratios stayed roughly the same. And I think Juha had shown some studies about this as well. More recent studies were shown. This goes back to the original, these studies go back to the 1970s and the early 80s. And this is when we looked at Japanese immigrants from Hawaii and California. And this is like epidemiology, environmental epidemiology 101, right? So as the Japanese, this was the rate of stomach cancer in Japan. When they moved to California, it dropped, but then, Nisei, the second generation, it dropped even further. But this was the native Caucasian male. It seemed to approach it. And so the flip side, colon cancer, is they're eating more In-N-Out burgers, right? The colon cancer rate's going up. So this is classic diet, environmental factors. And it's hard we need to tease out, I'm a 1.5 generation Asian American. What's my estimated risk? And I think we can tease that out as per Dr. Koh's recommendations. This is the other concept I'm going to bring up as someone who's an endoscopist and a public health person. So we need to think of gastric cancer screening in the context of the vehicle that we're going to use, or the modality, and that's going to be upper endoscopy for now. And so when we do an upper endoscopy, I hope we're also looking, even if you're doing gastric cancer screening, we're examining the esophagus. And then the other GE junction tumors are difficult because there's a lot of misclassification and really just difficulty knowing where the tumor origin. But even genomic type analysis, such as the TCGA, show that esophageal adeno, GE junction tumors, and proximal stomach cancers are very similar biologically and have similar risk factors. So I think there's something to this. We've talked about focusing on Asian Americans, which I'm all for, but I think there's something about thinking about this comprehensively in an upper endoscopic context, and I'll get to that. So this is gastric cancer that has been declining, and we've seen that. And this is esophageal cancer, and it's actually, if you just look at adenocarcinoma, there's been more than a 6-fold rise. And GE junction, this is very difficult to tease apart, but definitely not going down. Now, if you look at subsets, and now I'm getting into some squamous cell, we've really focused on adenocarcinoma because that's associated with Gurdon-Barrett's. But if you look at squamous cell, blacks, particularly men, have a 3-fold increased rate compared to whites. This isn't mentioned much, it seems like. And then also esophageal squamous is also much more common in foreign-born individuals, particularly China, of course, where 50% of all cases are in China at this point. So I'm going to go, Juha, how am I in time? Am I okay, good. Uh-oh, you shouldn't have done that. So this is I'm a modeler. I like to make projections. So the U.S. this is all from the Pew Foundation. They have this great PDF with some amazing stats. First generation, we as a country are about 13% have foreign born. If you include second generation, we're up to about 24%, or 81 million Americans. So that's a sizable percentage of the population. Furthermore, it's projected by 2050 that first generation will be up, including second generation, will be 37%, either first or second generation. And this is not surprising. We're seeing a lot of like maps, but where are the foreign-born people? West Coast, Northeast, Southern Florida, and then Texas. This is the percentage of foreign-born population who by these categories of European, Canadian descent or origin, South and East Asia, so that's together. Other Latin America, and Mexico has its own category. So I want to point out that I know we've been talking a lot about East Asians, but the other really high areas are the high mountainous regions or the Andes Latin American nations, right? Every country from Chile all the way up to particularly Guatemala has one of the highest rates. And then parts of Eastern Europe, including Belarus, has a very high rate. It's a small country, but a very high rate of gastric cancer. So this isn't just about East Asians, although we do probably bear the largest percentage of the disease. So these rises mean that we need to be ahead of the burden. Okay, so this was my thought experiment. I wanted to do a GLOBOCAN, and I know you've seen a lot of hot maps of IR GLOBOCAN data, but I wanted to combine gastric and esophageal cancer, and that's both adeno and esophageal. And the reason is that I'm thinking of it like screening them using upper endoscopy, as I mentioned. And from the U.S. perspective, I wanted to compare combined rates of incidence for both esophageal and gastric with colon cancer, because colon cancer has been reimbursed by Medicare since July of 2001. And the goal is to try to identify the patients or subgroups who are really high risk. So we did a little, and I want to thank Rick Peak, who gave me some early feedback on this. We took some IARC data, all publicly available. Then for each nation, we combined the gastric and esophageal cancer rates. And we looked at both incidence and mortality, and we divided by men and women. As you know, men have about 50% higher rate of stomach cancer through much of the world. And then what we did was we wanted a country was considered, quote unquote, positive if their rate was equal or higher than the U.S. colon cancer equivalent. Okay, and so what we found, now this is, the left column is men, the right column is women, the top is incidence, and to be honest, incidence is probably a little more fair, but mortality. But mortality, when you look at male mortality rates from gastric cancer, this is about 180 nations out of about 230 in GLOBOCAN, so about 85% light up. The smallest group is incidence in women. So this is a little bit of a statement. At least we need to drill down. There's some limitations to this, particularly mortality. Mortality is a little bit of a slippery rate, but this was a message that perhaps we're disregarding a large percentage of U.S. foreign-born and second generation who come from these regions. So this is not the same heat map. This is the combined one. And the countries, the dark blue means that it exceeded colon. The light blue or the lighter shade means it came within 20%, because the standard, the uncertainty around the measurement is about 20%. And so, again, male mortality, a large percentage of the world lights up, including parts of Africa, and the incidence a little less so. So I'm not going to get into the imitations at this point, but part of it is that the risks involved, and we don't know. Like a second generation person's estimated risk We can't just say, well, you're from country X, we're going to approximate that risk, and that's a difficult issue. And as I mentioned, colon cancer is a pretty good screening test because the screening is actually a preventive study with high levels of effectiveness that's been documented. So in conclusion, to the question that Juhat asked me with,
Good answer.
is there sufficient burden? I say yes to targeted screening. As many of others have said before me, the epidemiology in the U.S. is highly heterogeneous, but there's the burden is high in certain areas, and I think we already can identify high-risk groups for screening, surveillance, and prevention. That said, I think we do need some more work and some science to refine the patient profiles. So for example, what are the interactions with smoking, and what are the risks in second and third generation, let's say, Chinese or Japanese Americans? And then finally, I didn't get into this, but yes, we need better biomarkers. We need better, less invasive ways to screen. We need better chemo prevention. And then the flip side is pancreatic cancer. The reason pancreatic cancer doesn't make screening make sense yet is because the treatment still isn't very good. But that's a story to be continued. But as treatment continues to improve, that calculus will further benefit screening. This is my research group at Columbia, particularly Aaron and Monica, one of my GI fellows, did a lot of work with this analysis. And then finally, I want to put it, even though I'm in Palo Alto in the Valley in California, I want to put in a plug for the Columbia Stomach Cancer Screening Center. Even though Honolulu by far has the highest percentage of Asian population, over 65%, New York is not that high, but New York has over 1 million Asian Americans. And it's 40% foreign-born. So not just Asian Americans, we have Latin Americans from high mountainous regions. So that's part of the reason, part of my reason why I'm embraced stomach cancer as migrated south from Boston to New York, but also from the esophagus to the stomach.
Thank you.